There is nothing else right now that is really managing and lowering cost at the same time that it is improving quality and clinical outcomes.
Everyone is in a different place in terms of their journey with value-based care. Each organization's ability to take on risk, sort of like all the things that surround, and who is in the best position to build or provide that help.
The models are intended to sort of widen that on-ramp, bring in those safety net providers, and make the financial model more sustainable for them and for others.
Some of our ACH members they're the largest in the country, and some of them are, I would say, health systems beyond just being a health center.
The model incorporates what works for high needs populations in reach into more of a whole practice, whole clinic, whole health center. At the end of the day, right, we want the same thing, which is better, more accessible, more affordable care.
Welcome to Community Health Centers Unfiltered, the official podcast of Advocates for Community Health, where we go beyond the headlines to unpack the policies impacting our nation's community health centers. Today's conversation focuses on the future of value-based care and the role community health centers will play in the next generation of federal payment models. The Centers for Medicare and Medicaid Services is rolling out new initiatives designed to accelerate the shift from volume to value in healthcare. Two of the most closely watched models, the Access model and the newly announced LEAD model, are designed to expand accountable care, encourage technology-enabled care delivery, and place greater emphasis on outcomes, prevention, and care coordination. But as federal policymakers push forward with these new models, important questions remain for health centers. How well do these initiatives account for the realities of the safety net? Do they create meaningful opportunities for community health centers to be able to participate in value-based care? Or do structural challenges like attribution, infrastructure, investment, and patient complexity still stand in the way? To help us unpack these issues and questions, I'm joined today by Emily Brower, CEO of the National Association of ACOs, and together we'll explore what these new models signal about the future direction of federal health policy, how they intersect with existing accountable care organizations, and what policymakers need to get right to ensure community health centers can succeed in value-driven health systems. Let's get into the conversation. There's a lot to cover. Hi, Emily. It's great to see you. I'm really excited for our conversation today, but just to get us started, could you just introduce yourself and tell us a little bit about where you come from, who you are?
Yes, absolutely, Amanda. Thanks so much for having me. So I am currently the president and CEO of the National Association of ACOs, NAACOS, as we call it. And I've been in that role for a little over a year, having been a member of NAACOS, so in the membership, and served on the board of the organization when I was at Trinity Health, leading clinical integration and population health there. But I started off my healthcare career in the Boston area with a medical group that may be familiar to some of your Massachusetts members, Urban Medical, and was part of the East Boston Neighborhood Health Center led replication of the Unlock model that we all now know as PACE. So got to know the community health center leaders and network really well during my time in Massachusetts. So some fun connections going back to those early days. We didn't have the words that we have now, but certainly managing total cost of care for high needs populations through a community-based network. So that's sort of the roots of my career in healthcare.
I love it. I think I'm really excited for our conversation, Emily, especially to speak with you in your role right now. But honestly, I feel like you've been on all sides of this. And so I feel like that gives you such a different and a unique and invaluable perspective. So I'm really excited. And it's funny, you mentioned East Boston, now Neighbor Health or Neighbor Care, but Manny Lopes was actually one of our founding members at ACH, and just cannot say enough amazing things about Jack Craddock, obviously prior to Manny, but really the entire team, and what an incredible health center. And talk about best practices and models and trailblazers between, everything that they did with PACE, what they've done in the ACO space, of course, ACH, and so many other things. So and their current CEO, just another really, really outstanding leader. But I digress. I can talk about our members and the amazing elements of health centers all day long, but I want to dig into this conversation because there's so much. So my first question for you is that CMS has released a couple different models, Access and Lead, and I'm really curious to hear from your perspective. Do you view that CMS is trying to solve a problem? What does this look like in terms of these initiatives, and are they targeting the right challenges in the healthcare system?
Absolutely. And certainly there were a flurry of models. And for our members and your members, you mentioned Access, we can sure touch on. Lead is really the one that we'll probably spend a little bit more time on, since your members may be participating today in ACO REACH or the Medicare Shared Savings Program. So this is sort of the next evolution of the ACO model. And the other one you did mention is AHEAD. So there are 5 states where AHEAD has an ACO model component called GEO AHEAD, and we'll make sure to get the model information in the show notes and all that. But Rhode Island, Connecticut, Vermont, Hawaii, and Maryland. So to the extent that you have members in those states, I would add that to the list. But yes, absolutely. The ACO model in Medicare, so traditional Medicare beneficiaries attributed to one of those models I mentioned, have been successful. So you can argue whether it's 3% or 5%. You can look at some of the positive deviants earning 10% and more in shared savings, but it's successful. There is nothing else right now that is really managing and lowering cost at the same time that it is improving quality and clinical outcomes. That is the ACO model. So yes, absolutely, CMS wants to expand that. Chris Klump has said many times that I'm sure many of your members have heard and read about. He wants to 10x the savings, he says, in ACOs, and he would like to see every Medicare beneficiary make a choice between Medicare Advantage and an ACO, so that nobody is left out of that better care with more sustainable spending. So very specific and very transparent goals around that. So one way to get there, and according to Chris, you can get halfway there through getting all Medicare beneficiaries aligned. So having ACO models that bring in, attract, and enroll more providers, whose then patients will be attributed to those models. That gets you about halfway to the 10x, and then the other half is performance of those beneficiaries. So yeah, it's very explicit to get more providers in. And in the early days of the ACO model, there was not a ton of participation from community health center providers, community health centers and the providers that are part of those clinics, because it sort of conventional wisdom was the math didn't work. So, and there was too much risk for those entities to take on with what seemed like a not sustainable financial model. So, the models are intended to sort of widen that on-ramp, bring in those safety net providers, and make the financial model more sustainable for them and for others.
That makes a lot of sense. And all of the things that you're saying are consistent with, what I certainly have been hearing over the course of years at this point for, where and how people are in the journey. And you and I talked about this in terms of everyone is in a different place in terms of their journey with value-based care and, contracting and ACOs and whatnot. But I think some of the things that you just hit on in terms of making it more palatable and feasible in terms of the on-ramp, and there's just been a lot of progress made. So again, I'm excited to talk about all of the things we're going to get into today, just because I think it's going to show just how far we've come, but also how much further we have to go. But one of the other questions I had for you right off the bat is that there's often confusion between ACOs and value-based care more broadly. And so I'd love for you to speak to how policymakers in particular should be thinking about the role that ACOs play in that larger value-based care conversation and ecosystem.
Yeah, so earlier in the advancement of ACOs, I had this slide that was like the terms that we use. And so some people say the ACO is the O of the ACO. It's the organization or the network. Other people talk about ACOs as sort of shorthand for the Medicare value-based payment models, right? So it kind of depends, but either way, you can have the O of the ACO, the network, taking accountability for total cost of care and clinical outcomes in Medicare. That's the Medicare ACO. In Medicaid, which many of your members do today, in commercial agreements, even on the exchange, we have some members who have product on the exchange. So they are accountable for total cost of care, clinical outcomes for a defined population through their ACO that participates in all those different populations and product lines. So you can, you can think about it either way. Otherwise, you say the ACO is the type of contract where people are attributed but not limited, right? So it's not an HMO. It doesn't have that sort of fence around it. You are attracting people to your network and the model of care because it's better and it feels more accessible and all those good things. But you could be doing an ACO-like contract in commercial agreements. You might call that broad network PPO. So it sort of has become shorthand for a lot of things. But yeah, there certainly people use them interchangeably. So, the ACO being the network or the ACO being the contract, but shorthand being, accountable care, value-based payment model. That's sort of the way I think about it, is one is the clinical model and one is the payment model.
Thank you. That's helpful. And I think, it does get messy. I think if you're not in the weeds of it every day or consistently, it's easy to sort of say, wait, okay, thought I had that, but I'm not sure if I actually do. I myself find that there are moments where I encounter that. And I think, we'll talk about this more, but I think in the health center world, because everyone is in such a different sort of space on that journey, like I said, I think there are even some who feel, embarrassment's not the right word, but maybe some intimidation, because it is its own language at times. And if you're not sort of in the weeds of it, it can feel really overwhelming. And so part of the reason I'm excited to have the conversation today is honestly not some demystification and just updating about what's going on. And like I said, sort of what's worked and what's gone well and what are the things we need to work on. But I think just having a more open dialogue around what this actually looks like and how people can take advantage and how they can engage. But another question for you. So how does NAACOS think about community health centers within the broader value-based care landscape? There's like 3 questions within this one, but maybe we just start there with that one. And then the next piece would be, from your perspective, does it make sense for health centers to participate independently, or would it be more strategic to join a broader ACO structure?
Yeah, so we have many members of NAACOS who are community health centers and either are participating in these models themselves through a coalition of health centers, or maybe through another broader entity, like one of the enablement companies or a clinically integrated network that's put together in a community, maybe initiated by a health system. But in the latter, I think you're talking about broad networks that include health centers. And then the former are sort of coalitions of health centers that work come together to participate in these models. You do have to have a critical mass of aligned Medicare beneficiaries. So that's often hard for one primary care clinic or health center to have enough beneficiaries on their own. So there is just a numbers test where you need to come together with others to meet the beneficiary minimums. And then the other is the infrastructure that you need to build to do this. So if you've spent years doing this for other populations, most commonly our members, have a lot of experience in MA. And so it wasn't a big leap to say, okay, we've got, claims analytics, clinical models, all the things you need to be successful in Medicare Advantage. I can parlay that into participation in a Medicare ACO. So that's sort of the closest cousin, right, where you've got an infrastructure that serves both. You can get to that critical mass, you can scale. If you have to build all of that, so if you haven't done total cost of care arrangements, then it's just not going to make sense for you to try and do that one-off for one population. You really have to build on something. And if you don't have a lot to build on, then partnering with somebody makes total sense because there is quite a bit of infrastructure. At the end of the day, the most important thing the practice brings is access, yep. Right? And community health centers are great at expanding access, multiple access points. And so they have that core competency, but all the things you need around that, it doesn't make sense to build it for one contract. And sometimes you can get to that scale or that infrastructure by partnering, being part of a larger network. So I think that's more commonly how we see the membership, either through state-based CINs that are built around the PCA or through one of the sort of coalitions like C3, Medical Home Network, Health Choice Network. Those are all members of NAACOS. And then, as I said, some of our members who are enablement companies like Aledade have health centers in the network. Many of our health system clinically integrated networks, you could call those enablement companies too. They often have the community health centers that are in their community and in their sort of natural network as part of their ACO. So I think there are multiple pathways, and a lot of it is going to depend on who feels like the right partner and can bring that infrastructure and scale.
It's you. I'm thinking about literally countless conversations that I've had over the course of time with different health centers who are, trying to figure out what is the best route for them. And, I think everything from each organization's ability to take on risk to, like you said, sort of like all the things that surround and who is in the best position to build or provide that help. And, I think health centers in particular, and I'd love to hear more about your other members too, but I think health centers in particular are charged with so much already. I think the idea that okay, now we have to build this other thing around it, the question becomes, to your point, do we try to do that ourselves in coalition, or do we engage a partner and enabling organization to be able to take some of that on? And I think it's happening in iterations, or at least it has been. I think where some start in one space and then they gain experience and exposure, and then they may end up somewhere else. So I'm sure from a membership perspective, Emily, it's probably really interesting to see what that looks like over the course of time and sort of how people come in and out of the space in different capacities. But the other thing you mentioned that jumps out at me too is the importance of payer mix and how that can really influence decisions in terms of what makes the most sense from organization to organization. I want to talk about these new models. I know you mentioned that LEAD is much more sort of probably where our health centers are going to land, but I want to take a minute to talk about access, just because I think it emphasizes in particular technology-enabled care and an outcomes-based payment rather than an activity-based reimbursement. So what stands out to you with the approach for access, and where do you see potential gaps or challenges for health centers in access specifically?
Yeah, so on the plus side, I think the transparency around access and the ability for a provider group and ACO to see who are these entities that are signing up, what is their model, and how are they doing, right? So you mentioned the different way that that access is setting up outcomes-oriented payment, right? And one of the things they're going to be doing is transparently sharing how these access providers are performing against those metrics. And so, and an ACO, right, most of our members today are trying to figure out how to leverage advanced technology tools to get more scale and touch more patients than they can do today. And so there's sort of a marketplace, if you will, with data and evidence for an ACO to be able to look at and evaluate those providers. So that's a good. The other is that given the very small payment that we've now seen that comes with this model, those access providers, one of the biggest costs they have is participant acquisition, right? How are you going to reach out to 10,000, 100,000 eligible beneficiaries to get a small number that will sign up? So an ACO is a great partner for that. If you've got something that an ACO needs, being able to do that participant acquisition through a natural partner like that, someone that already has a relationship with the patient. So there's an opportunity for alignment through there. So that could be another possibility. Our members are also, sort of thinking about the other side of this, particularly those that have implemented programs for some of those same populations and maybe have done the work to integrate it into their workflows and their EMR and all that. So they may have a program in place. They're more concerned about their patients being redirected to a different program and losing their participation in the program that they've done the hard work to design to meet their needs. So, folks are looking at that too, as the participation and the engagement with the provider that's built into the model as an opportunity to make sure that that's a patient that's not already engaged, right? If it's patients that the ACO isn't working with today, right, which is never going to be everyone we want it to be, right, there's another opportunity alongside what they're doing. But of course, people have a concern about yet another point of communication with patients whose care is already so fragmented. It feels like let's not fragment whenever possible.
Yeah, that makes a lot of sense. So then let's switch to LEAD. And I think for this model, there's an increasing federal focus on prevention, care coordination, and whole person approaches, particularly as it relates to chronic disease management. So I'm curious, what do you think this shift tells us about where CMS believes value-based care is headed? And then what guardrails do you think are needed to make models like this workable for community health centers?
Yeah, so in LEAD, and there's some detail, but we don't yet have what I refer to as the math paper. So we don't really know how this will all come together into a model that a provider group would participate in. But based on what has been shared, and again, we'll make sure the link to the model pages in the show notes, but it is sort of the next step forward in an ACO model, and it tries or intends to address a couple of very important things that we and our members have been advocating for a long time, which is a more sustainable benchmark or financial model to understand what that is going to look like. So a 10-year model without having to reset or rebase your benchmark every couple of years. So being able to understand how am I going to be paid at the end of the day, right? You got to know how you're going to be paid. And what is the benchmark? Because if I'm going to be able to model out what dollars I can invest in this, I need to understand what the benchmark is so that I can model some performance against that. So a 10-year program with a more sustainable benchmark is a very good thing, and should attract more interest, particularly from folks who are in this for the long run. Mm-hmm. So if I think about community health centers that have been in their communities for decades, serving that community, they're not going to pick up and go to some other county because the benchmark is better there, right? It's got to work for us today in the community we serve. We see this also with many of our community hospital or health system members too. Mm-hmm. They're in the community they're serving the community. So they don't have as much flexibility for saying, oh, I'll add this 10, I'll drop this 10, I'll move to this county, I'll leave this county. It needs to work for the long run. Mm-hmm. And so that's a really promising approach. It's very responsive to what we've advocated for, so yay. The other thing that is distinct, and I think a good step forward from REACH, is rather than having to choose, I'm going to be in a high needs track or not, the model incorporates what works for high needs populations in REACH into more of a whole practice, whole clinic, whole health center, you could say, approach. So you don't have to choose. For a smaller population and a smaller number of providers who are high needs, the REACH had a better math, math detail for them, better benchmark, better risk adjustment. It makes more sense. But if you chose that, then you leave out all the other folks who could be in an ACO but aren't in that high needs track. So that, I know that sounds like a little bit of over detail and weedy, but that is a major step forward to say, we're going to take a whole practice, a whole clinic, a whole health center approach. And for those Medicare beneficiaries that are high needs, they will get that better match of a benchmark and risk adjustment and the things that you see in REACH. So as I said, we haven't seen the detail in the RFA and the math around it, but that is certainly the intention, and they've communicated that pretty clearly. So those are two really, really important sort of evolutions that are responsive that I think will make this attractive to particularly to community health centers that are in REACH today, but even those who are in MSSP to take another look at the CMMI model, in this case, LEAD.
Yeah, I think that's one of the things that I have really appreciated in just working with the folks at CMMI recently, but going back quite a long time, is they really are quite responsive. They do listen. They want the information and they want these models to work, and so similar to you, ACH has done a lot of advocacy around what the realities are for health centers specifically, and where some of the challenges and the barriers have existed in the past. I think the other challenge, and this is not, there's nothing to be done about it, because, when you launch a model, you're launching a model, you have to see it through. You can't necessarily change midstream. But I think that's the other thing that I think is difficult at times, because there is so much learning that comes along the way. And so building in any capacity for flexibility, to your point, it's sort of like, okay, we need the predictability and the value of the 10 years, and the whole organization approach is incredible. And also, it's sort of like, okay, but what happens when we discover these things in year 3 and 4 and 5, or whatever the case may be? And so, I think having some opportunity for that flexibility, or at least to, I don't know what it looks like, but just to take those learnings and the discovery and translate it in some way to continue to strengthen and build. But then that disrupts data, and there's lots of other things that make that sometimes infeasible. But I'm curious, it's maybe too early, but do you see any challenges, or do you see any barriers with LEAD at this point? There's still a lot of information yet to come, obviously, too. But there's lots of pros. I'm just curious if there's anything that you're sort of watching with a little bit of, not sure how that's going to work.
Well, nothing like that's like a warning, like, sign. I would say we just need to see the details. What is some of the sort of how to adjust the benchmark for a population, thinking about your members, right, who's more likely to be part of a community health center population. So is there's going to be a benchmark adjuster for dual eligible status, mm-hmm. low income subsidy, what they used in REACH, the area deprivation index, which, has pluses and minuses, but, what is that differential going to be for participants who have more Medicaid, more of a population that has Medicaid as well. So it's really just about the details. But the point you make about flexibility. So one of the things that the model team has already put out through the sort of the model papers, what they've already published on their model page and the fact sheets and those kinds of things, is that there are going to be things they will add to the model over years, right? It's a 10-year model, so it's going to have to flex. So one of those is the incorporation of Medicaid in 2 states. That is both an opportunity for participants to weigh in and shape that, right? Because it's not at the start, it's going to be further out. That the choice of those 2 states is probably going to come a lot from the input of the people participating in the model, right? So, people like working in innovation center models because they do evolve over the model, but for some people, they don't like whatever the decision is made, and they wish they were in MSSP where there's rulemaking. There's a proposed rule with a comment period, and it's more structured. It's not that it doesn't change. It's just more structured, and it happens once a year through this process. Right. In CMMI models, it is kind of happening all the time. And so there's the good of that, but if you're on the other end of some of those changes, sometimes you feel like you have whiplash.
Yeah, agreed. Although, a word that has been coming up and is really, I think, from inception at ACH, but what's been coming up a lot in conversations is just the need in this particular time to be agile, and how valuable it is, even to what you're speaking to, is just sort of things change, and being able to sort of adjust and respond to that wisely and with a solutions-oriented lens. I think sometimes right now there is so much change, it's easy to find yourself in a little bit of paralysis. But I think moving back into that agility but I also agree with you. I think it's exceptional. I'm really excited about the flexibility that you're mentioning, but just the willingness to I mean, it's innovation, right? It's the willingness to try new things, to take the input and really try to translate it into policy and pilots and models that can be truly impactful and lead the way for, what we can then scale across a wider system. The other questions I have for you are sort of focused in the safety net space and sort of what the reality is through that lens, because it is a little different. I think some of our ACH members are, they're the largest in the country, and some of them are, I would say, health systems beyond just being a health center, but it doesn't change the reality in terms of what it looks like to be safety net. And I'm sure many of your members face the same thing, but one of the things for health centers, and I think one of the challenges that health centers face, is that many of them are operating with very, very thin margins, as you know, and they also have limited access to capital, and then they have really, really complex patient populations. So when we think about those things, those are three things that are not necessarily, at least in my mind, I'm not in the weeds anywhere near the way that you are, but those are three things that are challenging when we are thinking about participation and engagement in this space. So how well do you think the current value-based care models account for those realities? We've talked about these lead and access and just sort of trying to be thoughtful about some of those things. But I'd say even just more generally, how much do you think those realities are factored into the approach that's available right now?
So, certainly there is deep awareness of those realities. I would say, the folks, the staff at CMMI and the leadership at CMMI today, many of them came from operating these models, participating in ACOs and other entities that are doing these models. So they have, and plus we've just been doing it for a while now, right? So I think there's good experience and insight. And so many of the features, starting with REACH, but what will continue and lead, or what's new and lead, is absolutely intended to address some of those things. But at the end of the day, and I am not by no means an expert in prospective payment, but at the end of the day, right, it's ACO models are built on traditional fee-for-service. And so for our safety net health systems, clinics, anyone who is paid prospectively, there's just like right at the start, there's a mismatch. Now, there are things you can do, submitting cost reports more frequently. I'm sure the things that your members know way more about than I do about how to bridge that gap. But, that's a piece of work, and that exists. I've not seen anything that says, we're going to have a separate ACO model for entities that are prospectively paid. Instead, there are these attempts to adjust the benchmark to recognize that there's different utilization, there are different populations. While there's no incorporation specifically of social risk factors, there are attempts to sort of adjust the benchmark for different population types. And so there is explicit intention, understanding, and efforts, but nothing that I've ever seen that goes so far as to say, this model is going to align with prospective payment, so that we're not forced to sort of live in these two different worlds of payment. Now, if you're in a CMMI model that has taking advantage of the capitation opportunities, maybe you get closer. If you have these adjusters for dual eligibility, et cetera, maybe you get closer. But we also know, and I know it is not all about those who are dually eligible, but there's certainly more who are dually eligible and enrolled in our health center membership. And that the care model can be completely different if someone is dually enrolled because they've aged in versus because of disability. So they qualified for Medicare under 65 because of a disability, this is a totally different care model than folks who have Medicare and qualify for Medicaid because of poverty, but look clinically like an over 65 Medicare population, right? Totally different care model. That's why the community health center model works so well for the duals under 65, because at the end of the day, they look a lot more like people with Medicaid than the over 65 that look a lot more like people with Medicare, non-duals. So there's nothing that explicitly says this is how we're going to solve for that, but all these sort of adjusters are clear that they're trying to make the model work better for a health center participant or a safety net participant.
Right. Yeah, I think, that one might be a little bit of a holy grail. If we can figure that one out, Emily, I think we'll have lots of other work to do, of course. But yeah, I'm not sure if that was an easy one to address, or those three things were easy to address. We certainly probably would have right now. But I mean, those three realities are those that come up consistently each and every time I have a conversation where that's what they're trying to figure out. And honestly, how to make it work best. And some have done more. Again, I think it depends on the organization in terms of even the resources that they may have in order to take on some of those challenges themselves versus bringing in outside partners and you name it. But I'm glad the awareness is there. You're at least confirming that there's an awareness and good intent. Hopefully we will eventually move into a space where there is that very deliberate and designed, approach or solution to solve for that, but might be down the line. We'll see. Another one that I think comes up a lot in terms of the reality for health centers in particular has to do with attribution and patient churn. This is definitely, I would say, much more relevant in the Medicaid population, but it's just a huge challenge, as you know, for health centers. And I guess my question for you is more on the policy side and policymakers in particular. Do you think that policymakers underestimate how disruptive those dynamics are and can be for value-based care models?
I think those that are aware are aware of how disruptive it is and how the models really don't do a great job at paying for care for a population that is coming in and out of eligibility, is seeing multiple providers, doesn't retain consistent attribution, right? Those are just problems in general for these models, right? These models work for people who have a consistent primary care relationship and consistent coverage. So I say that, I smile when I say that, because I know that there's a lot of inconsistency for our safety net providers in both of those things. But the models really are built for that. It's so what one thing in LEAD, right, that's there that we can see in sort of the fact sheets is there will be the ability to attribute beneficiaries at multiple points throughout the year, and to add providers, right? Because some beneficiary enrollment changes happen because their PCP moves, right? So being able to add providers in the middle of the year. So those things should help, right? More ability to bring people in and bring providers in. So it helps sort of on that end. So the churn that happens when people have multiple relationships and are not accessing regular care regularly. Mm-hmm. And then at the other end of the spectrum, you have folks who getting care from a lot of different providers in a community, right? So they're more complex. They're more, seeking care from a lot of different providers. and the ability to use voluntary alignment is really important with that population. So there's another tool, we didn't talk about that earlier, but that's another tool that that ACOs can use to try and solidify that relationship. When someone, like if you ask the patient, they would say, yeah, that's my PCP. And if you ask the PCP, they'd say, yeah, that's my patient. That care patterns and encounters, like the claims methodology, doesn't match. That's where voluntary alignment works. So there is recognition for sure. I don't think there's anyone who doesn't understand that working with a Medicaid population that has to re-enroll, and then those two sort of subpopulations of people who have a small amount of care from multiple providers and have a lot of care from where there are a lot of different access points, specialists and hospitals, right? People understand that and see that and are giving ACOs some tools to try and make that better. But it is a feature of a broad network model like an ACO, and you could say the same would be true with a PPO, which at the end of the day, Medicare is a national PPO, if you think about it that way, right? Which is, there is nothing that puts that fence around the patient and the provider. And so you're just going to see, more turnover in the population. I think that's what you live with in one of these models. And so things like voluntary alignment, multiple alignment points, and trying to increase stickiness of your provider network as well should help, but it's not going to solve it. It's just going to help.
Yeah, it's interesting. Just kind of as we're having the conversation here, I think it's not new, but I think the awareness, to your point, certainly exists. I think, within CMMI, I think people who are familiar with this and working on it proactively. I think where we need more education, or there's more to do, and it's sort of a dotted line, but I think about what's coming with HR1, in 2027 and some of the policy decisions made with that. I think there's a disconnect sometimes between, okay, that's fine. We see and understand the issues you're trying to address here, but also, do you understand the downstream and potentially negative effects that happen over here? And it's messy. I say that with also the recognition of, like, there's not a simple answer to this, but I think sometimes those decisions, like what's happened with HR1, and again, whatever the intention, I'm not staking good, bad, indifferent, but the reality is the impact that it will have on what we're talking about with this in terms of value-based care and, impact for ACOs, you name it, is really significant. And I think, more so certainly in the Medicaid population, I think it's different when you're looking at these two things, but there's also lessons to be learned on both sides. So, as with all things healthcare policy, it's a much deeper, it requires a scalpel, to say the least. I say that a lot. I think sometimes the approach that's taken on the Hill is a sledgehammer, and we really need a scalpel, but that takes time. And I do, going back to, I appreciate CMMI and CMS that they are really trying to take that really detailed, finer approach. But it's difficult when you think about the other policies that are circular to it and the impact that it'll have on it. But I know we're getting down on, sorry, go ahead.
No, I was just going to say that's what's going all around this, Amanda, right? Like that, what can feel like chaos or just constant change in fee-for-service payment, and is sort of what's happening around this. I mean, you can't minimize the amount of change it takes to really deeply invest in and embrace these models. And for our members for whom this is a strategic investment, they have a hypothesis, a theory of change, that this is going to be better for the people and communities they serve. Yeah. And you can stay on that track, right? It's hard, right? You're swimming upstream, everyone else, all the rest of, you have so much fee for service around you. And anytime there are significant changes in that environment around you, right? You got to turn and address that, right? And that means you can't spend as much time, invest as much energy and strategy around total cost of care, moving into population health, leaving fee-for-service. And fee-for-service is always around you and always changing. It's just sort of a fact for our members, even if they're not, as affected by HR1 and some of the Medicaid changes. It's still out there, and it's pulling attention and resources away from this work, which requires significant change management.
Yep.
Right. So yeah, it is super challenging. We actually, NAACOS, we have two national conferences a year, and our next one is in April, and we're doing a convening the day before the conference just for our health center members, just to talk about forging this pathway, which for many of them is strategic and involves all that change when the environment around them is pulling so much of their attention. And even though the fee-for-service payment is not sustainable, it is still the way most people are paid. And so any change there is just going to pull people's attention. And so there is that, just keeping the focus on the pop health strategy.
Well, and I think, to your point, and again, not to overemphasize this sort of like there's the global or the circular, everything that's going on around. I think for health centers right now also, it's, you have the impact of HR1, you have continued, uncertainty and instability in terms of grant funding, which also hasn't really, we're very grateful for the increase that we saw just recently this go around, but it's nowhere near what is actually needed. And then you have the erosion of the 340B program. So they're getting hit on all sides. And, I think sometimes I won't even comment on whether or not, there's a strategy behind that. But when you have 17 fires going on, you can't possibly get to all of them. You really have to prioritize which ones you're going to take on first and not leave the others to happen how they're going to happen. But I think, to your point, even if they are, committed and resourced and all of the things to be able to be successful in the models that we're talking about and with their ACO and wherever they exist in the space, the distraction and the need to focus on the other elements really detracts from what that overarching success can look like. And that's another one, which, to be honest with you, I'd love, maybe we can talk offline about things we can do together to help support in that way. There's certainly bigger kind of global needs and initiatives in that. And obviously ACH exists to be able to address some of the policy and advocacy around it. But it's interesting because I think that's something that's overlooked a lot. It's just sort of, there's tunnel vision on what the ACO and or value-based care is and is, the direction that it's moving in without considering all of the other pieces that end up impacting it. But I know we're getting short on time. I have one more question for you, or actually I have a couple questions. I'm going to change us over to looking ahead because let's think about where we go from here. So the first question is, if CMS wants community health centers to be fully participating in value-based care 5 years from now, are there policy changes or investments that you think would need to happen today in order to make that feasible?
So I think some of the things we talked about earlier around adjustments to the benchmark, or just say adjustments to the financial model that better reflect the population being served and the payment that your members, who absolutely are scrappy, right? There's a bit of 340B that helps support the ACO population. There's probably grant funding that helps support, right? And they identify all these and put it together into one package to sustain their delivery system. And so, yeah, any of that, right, is going to be disruptive. So any kind of adjustment to the financial model that recognizes this is a different population. There needs to be a different level of some additional financial support, whether that comes through those benchmark adjusters well, that's mostly the way they try and get at that. So that, I think there'll be more in lead in that recognizing and supporting the financial sustainability of a high needs population. What is that actually going to look like in terms of the math, and continuing to work at that. Right, that is not going to stop, because we're trying to make a benchmark that is essentially built on encounters, at the end of the day, sort of historical cost work for a population that you're trying to get more care for, right? Historically unable to get care from the traditional access points, finds their home in a community health center. You're connecting them with care. You're going to see an increase in care, right? So it's a different population. You don't have really true social risk adjustment. And so you're trying to jigger these other parts of the payment model to better reflect the population that a health center is serving. And so you can see that's what is being worked on in these models, and engagement with those members, participants, and the model is going to make that better, right? So it is sort of the everyday work of building relationships, advocating for better payment, that you do, that we do. And yeah, to the extent that we're doing that together and singing from the same songbook, right? That's helpful. That's helpful to the Innovation Center as they continue to evolve the models, right? So it's payment and risk adjustment really are the most important levers there, and then ability to reduce some of the turnover in enrollment through better voluntary alignment mechanisms and multi-year enrollment options. I mean, I think I feel like a little bit repeating what I said earlier, but those are the tools that exist, right? Would I would absolutely love to see something that better recognizes upstream drivers of health, social determinants of health, health-related social needs, all the different ways we have of talking about that. But I don't know that we're going to see that in the next 10 years, Amanda. So I think we try and really make sure that the puts and takes of the ACO model and the way the benchmark and the risk adjustment is done better reflects the needs of the population. We want that for everybody, right? But there's a particular focus for community health centers because of the population they serve. Everything else is going around them, and this really different trajectory of medical care and medical expense you see when someone who has had a hard time getting care from an integrated provider network lands there, finds their home there, and starts to get their conditions addressed, right? I mean, that is sort of a story that you see in the data, and the models are not great at that.
Yeah. Well, my last would be any words of advice or sort of guidance for health centers in the moment or going forward, but just sort of last words for recommendations for health centers.
Well, I think get ready to model both LEAD and MSSP. Sometimes the words like in LEAD sound like they're going to be better for you, but there are things like regional adjustment that maybe better in MSSP than it is in REACH. So I would say just start with a clean slate, be ready to model both and see what works best for you. and then, engage. So we have a large number of health centers in NAACOS, and we really encourage people to take advantage of their membership, participate, get the resources, learn from each other, do that NAACOS thing about shared learning and education, getting farther together, and really engage in that way, just to learn what each other is doing. Many of your members participate in some of these more collaborative networks. They probably do that today, but take advantage of the NAACOS membership. Come to the conference, and then I mentioned earlier this convening we're doing specifically for our health center members, their PCAs, their CINs, and their coalition partners, because they do have different needs from our other members, and we want to make sure we're serving them, but we also want to create that space for people to learn from each other. So if anyone listening today who's a member or even a non-member wants to participate in that, just email me, because that's why we exist, right? Is to be in touch with our members and help them be successful.
Well, I really appreciate even the fact that you're hosting that, dedicated session specifically for health centers and PCAs and CINs speaks to the commitment and the understanding that NAACOS has for what, differences and what the realities are for health centers, how it's different. So thank you. But I would say thank you even more so, one, for the time today, but I think for the bigger work that you guys are doing. It's so incredibly important, and there's so much more. I feel like I could talk to you for hours, Emily, just literally to soak it up and learn. So it's been really, really informative for me today. But I think we have, there's a lot of work to do, and I appreciate your words of wisdom and guidance for health centers to just do the modeling, and engage. And, going back to what we said earlier about agility, but very grateful to you and to NAACOS, and excited to have more conversations about this, because I think there are more models coming, and we haven't solved the problem yet. So there's going to be continued work to do for sure. But thank you so much for today, and we look forward to the next conversation.
Well, thanks so much for having me. I had a lot of fun in our conversation beforehand, and it's a great opportunity for me anytime I can reach our members and others who are doing the hard work, the blocking and tackling of improving care for the people and communities they serve. Payment is just a conduit for that, right? So at the end of the day, right, we want the same thing, which is better, more accessible, more affordable care. And your members are like right in the sweet spot for that. So I love the opportunity to engage, and we'll find ways to do more of that.
Sounds great. Thanks, Emily. We'll talk to you again soon.
Thank you.
As we wrap up today's conversation, one thing is clear. This shift toward value-based care isn't slowing down. Models like Access and LEAD reflect CMS's continued effort to move the health system toward prevention, coordination, and better health outcomes for patients. But as Emily highlighted today, the success of these models would depend on whether they truly account for the realities in the safety net. Community health centers care for patients with complex needs, they operate with limited infrastructure, and often they face challenges around attribution, payer mix, and capital investment that traditional health systems simply don't experience in the same way. If policymakers want value-based care to work for the entire healthcare system, community health centers have to be part of that conversation from the start. We'll continue following these developments closely as CMS rolls out the next generation of value-based initiatives, and as community health centers work to ensure the safety net remains strong in a changing healthcare landscape. Thanks for joining us today for this episode of Community Health Centers Unfiltered. If you enjoyed today's discussion, be sure to subscribe and share the podcast so more people can stay informed about the policies shaping community health centers and the patients they serve. We'll see you next time. Thanks for joining us.